Hi everyone, welcome to today's video. Today we're going to be talking about Finerenone, the latest medication that has been recommended by NICE in the management of chronic kidney disease in the context of type 2 diabetes. Well, first of all, let's talk a little bit about the context of this whole area. What is the unmet need? Well, chronic kidney disease is relatively common in people living with type 2 diabetes. In fact, 1 in 5 people with type 2 diabetes requires treatment for chronic kidney disease. However, despite that, the therapeutic options have, up until recently, been relatively limited to ACE inhibitors, ARBs, and more recently SGLT2 inhibitors. And despite these effective medications, there still remains in many people a residual risk of further renal decline and cardiovascular disease, and not everybody tolerates those medications either. So there's the unmet need, and that's perhaps where Finerenone comes in. Patrick, tell us a little bit more.
Yeah, so what is Finerenone? And it's a non-steroidal mineral receptor corticoid antagonist, MRA. So we've been using MRAs, steroidal MRAs, for some time, spironolactone and eplerenone. So Finerenone is non-steroidal, so that is different in a number of effects. First of all, you don't get the sexual dysfunction such as gynecomastia and erectile dysfunction, but you don't get the blood pressure reduction with this drug, and you get a fewer events in terms of hyperkalaemia. We'll come back to that later on, I'm sure, because it's important still in the context of DKD. So in terms of the evidence behind it, there's 2 large randomized controlled trials which have shown renal benefits in terms of reducing that renal decline and indeed renal death, as well as actually reducing adverse cardiovascular events, in particular hospitalization for heart failure. And
it's that evidence that NICE has really utilized to develop their recommendation. And what is NICE's recommendation? Well, it's for the use of Finerenone as an add-on therapy in patients with type 2 diabetes and chronic kidney disease who have already been established on ACE inhibitors or ARBs and SGLT2 inhibitors at maximally tolerated doses. So that's where NICE has positioned it. It's for patients with an eGFR above 25 mils per minute. So we've now got potentially a third option in terms of drug therapy for these patients. How does this play out in primary care, Patrick?
So I actually initiated it myself, so I've got some experience with it. I'm pretty certain it'll be an amber drug. It'll be for specialist use only. It's not the easiest drug perhaps to initiate because there are 2 different doses. What dose you give will depend on potassium levels and their EGFR. That needs to be monitored over a 4-week period of time. There may be further dose adjustments depending on potassium and EGFR again. So it's a little bit tricky. So I think the role in primary care is probably for us to, first of all, identify suitable patients, and then, because it's important, as you said, there's unmet need, there's residual risk, and then get advice and guidance, or refer, if that's your local pathway, to your local kidney doctor, who will give you more specific advice in terms of how to initiate and monitor. And then, of course, a lot of these patients are going to be discharged to us, even if they've been initiated within specialist care. So after 4 weeks, you're going to need to continually monitor that potassium level, no more frequently than you would do if they were on other RASI drugs. But it's in this group of people with chronic kidney disease and type 2 diabetes are particularly at risk of hyperkalaemia, so we do need to keep an eye on them. So I think that's I would say is the role of primary care.
You mentioned hyperkalaemia, and that's something in primary care we deal with on a daily basis when we're going through our blood test results, those borderline potassium results, and having to make a decision whether to seek specialist advice or even hospital admission. So, Patrick, is there anything that you can suggest, any resources, any support that we can refer to, particularly in the context of using medications that we've talked about and Finerenone itself?
Yeah, I mean, I think it's a really important area, is hyperkalaemia. And it has to be said, it's something which GPs probably need to know a little bit more about. I think it's probably one for your PDP. There is a very comprehensive guideline produced by the UK Kidney Association, but it's over 50 pages. So that's, I think, going to be difficult for us to justify, and certainly difficult for us to read, as you say, when we're going through all those results at the end of the day. So fortunately, the Edinburgh Renal Unit have produced a really helpful infographic, which they use in their community pathway. It's based on those guidelines I've already mentioned, the UK Kidney Association, and I would suggest you bookmark those and have those for easy reference. And that will, honestly, you'll be much more confident in managing hyperkalaemia once you've looked at those. Trust me on that one.
Brilliant. Thanks for that, Patrick. Really useful tip there. So there you have it, Finerenone. Remember the name. We're going to be seeing it a lot more in primary care in our patients living with type 2 diabetes and chronic kidney disease. That's all we have for you today, but stay tuned for further videos on this topic and others, and do feel free to reach out to us across our social media platforms. But for today, that is all. We'll see you soon.